On this episode of the ASC Podcast with John Goehle, we discuss the latest news and recent survey experiences, including a discussion on dealing with a rude surveyor, and we celebrate our 200th episode with the staff of the podcast and the staff of Ambulatory Healthcare Strategies, and we'll discuss current issues in ASCs.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. And Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 200 of the ASC Podcast with John Goehle for September 28th, 2023. We're recording from our studios in Spencerport, New York. This is Sue Cronkite, co-host of the ASC Podcast with John Goehle and operations manager for Ambulatory Healthcare Strategies. We would like to remind our listeners that the ASC regulatory environment is a rapidly evolving landscape, and the material presented in this episode is based on the most current information available as of the date of the recording. As such, it is important to recognize that this information may be subject to change, and we advise that all ASCs stay up to date with the latest regulations and guidelines that are issued by their relevant regulatory bodies. Joining me today is John Goehle, the owner of Ambulatory Healthcare Strategies and one of the most respected experts in the ambulatory surgery industry. With over 30 years of experience, Mr. Goehle has authored over 10 books on the ASC industry, and he is a sought-after speaker on regulatory accreditation and finance issues.
So we've been waiting for this for a while. I don't even remember celebrating our 100th episode, but here we are at 200 episodes, and we've been preparing for this for a while. We brought together our team, including all of the co-hosts before you, Sue. Not everybody knows this, but Sue has only been the co-host for 5.5 of our 6 years. We did have other co-hosts until Sue was coerced into doing this for the rest of her life. But it's an incredible 200 episodes, 6 years, grown from a very simple podcast to include our patron program, our premium access program, all the conferences and boot camps, et cetera. It's hard to believe that we've done that. It's still hard to believe that it's been 6 years that we've been working on it. So again, Sue, I want to thank you for taking on the responsibility of a co-host. Putting up with me for 6 years and 200 episodes has been no easy task. We've got a lot going on as we celebrate our 200th episode anniversary. We just announced 2 full-day conferences in November, on November 16th and 17th. The first one is on the 16th, is the Introduction to Finance and Accounting. That's a full day, 8 hours, and it is going to have AEU credits also. Conference kind of going through the very basic information about finance and accounting. And Sue, you and I we just did the boot camp in August for business office managers. And one piece of feedback we got not only from that boot camp but also from our patron members is that there really is a need out there for very basic introductory information about finance and accounting.
Yeah, everybody comes at it with a different level of experience and training, so we really have to cover all levels of that.
Yeah, and again, I don't want to pick on nurses any more than I normally do. But, of course, you don't have any training at all in any of your nursing classes on finance and accounting. And I think that often puts you at a disadvantage when you're going into leadership roles, such as administrators, even nurse managers have. So it's going to be a great conference. Again, it's November 16th, and for more information, you can go to our website at asc-central.com. We're going to talk about that new website in a minute, but it is asc-central.com, and there'll be a link to it in our podcast notes. And then on the next day, we're going to try to do this in the future, by the way, try to lump some of our conferences together so that we might even be able to package deal it or just it makes it easier for us to record them, of course. So the next day on the 17th, we're going to redo our Conditions for Coverage and Interpretive Guidelines Conference. We did that last, I think, Sue, in 2021.
I think so, and we think it really needs to be updated.
Yeah.
And this is something that anybody in any role at the ASC, I think, could really benefit from.
Exactly. Right from the very top, from the governing body, all the way down to, the receptionist, because it really is important that everybody, there should be no secrets about what the regulatory environment is in an ASC. And not everybody will get the same amount of information out of it, but there certainly is a lot to learn from it. So that conference is on November 17th. And again, it's all day. It starts. Both these conferences start at 8 a.m. and go right through 5:30. It's going to be a long day. And each of them will eventually get 8 AEU credit hours also.
And as you mentioned, they're always going to be recorded, so you can either buy them afterwards, or I think the best way to do it is really sign up if you can, attend it so you can ask any questions you want. And if you are pulled away inevitably throughout the day, when you get the recording, you can fill in those areas that you've missed.
That's right. And of course, if you're a patron member of the podcast, those conferences are no cost to you. Just send me an email and request to be invited to it. So again, patron members and members of our Premium Access program get admission to both of those conferences for free, but you do have to send an email. And there will be a communication sent out to all of our patron and Premium Access members. I did want to talk a little bit about our new website, ASC Central. The address is asc-central.com. It's a work in progress, but what we're trying to do is we're trying to move all of our conference material links over away from the ASC Podcast website to ASC Central. It's been getting a little busy on the podcast website lately, and we really wanted to find a way to kind of organize things a little bit differently. So I've owned the ASC Central domain for well over 10 years now and really hadn't done much with it, but we put it all together. We're still working on it, and those of you that are patron members and Premium Access members know that the asc-centralweb.com website is where you access those benefits. And, of course, as we celebrate our 200th episode, we brought all of our staff together. We didn't do it because of the 200th episode, but we just happened to do our semi-annual retreat in September, and we had all of our employees from Ambulatory Healthcare Strategies, both here in our home here in Spencerport, New York, and virtually through our teleconferencing capabilities. And at one point, we did two recordings. I think we lumped them together, though, right, Sue? In the interviews here. The first discussion was with all of the previous co-hosts of the podcast before Sue became full-time, just kind of reminiscing about some of those early days. And then we had an ongoing discussion with all the employees about what's really going on right now. We do this after every one of our retreats. What's going on in the ASC industry, and just observations from all the work that we do with our 80-plus clients throughout the country.
And I think you got nostalgic after talking about the earlier podcast, because I saw you have an idea about doing a skit in one of the upcoming podcasts.
Yes.
I think you must have missed that dramatic aspect of it all.
Yeah, absolutely. Well, and it came from a survey. I was just on a survey yesterday, and the surveyor kind of pointed out that the organization really didn't do a complete timeout. And it dawned on me, and when I was recommending to the organization, how to your staff to do a proper timeout, I said, why don't you just act it out? And throw some crazy ideas out there, things like that, just to kind of get everybody to, to pay attention. So we are going to do, I don't know how we're going to do it yet, but we're going to do a skit for one of our podcasts coming up to show you the perfect, we'll probably do the worst timeout ever.
What not to do.
What not to do. And then we'll do one where everything is perfect. So stay tuned for that.
And I saw something concerning with, there's so many problems with staff right now.
Yeah.
Now they are saying that Kaiser Permanente healthcare workers are possibly going on strike sometime. I believe that it would be before November because I think their current contract
ends in October.
At the end of October.
Oh, wow. Okay.
They're saying likely more than 75,000 workers might walk out for a 3-day period. They had originally, I think they had said October 3rd to the 7th or something, but they may be pushing it back. But they're alleging that there's have been unsafe staffing levels due in part to poor pay and benefits, despite the high profits that the company is making. So I think it's what a lot of people are saying everywhere is, the staffing just isn't keeping up. People are getting burned out, and then the more burned out they get, the more people leave, and it's just, it's
a
pretty
never-ending
concerning.
cycle.
Yeah.
We even saw it here in we live in Spencerport, New York, which is just outside of Rochester, and there was a situation where I believe they did go on strike for a few days.
I think they did, yes.
And then there was another situation we reported during the podcast in New York City about a year ago. With one of the major systems there. So I think, I don't know if this is escalating, but it certainly is a problem, and it does seem to be centered around our challenges right now with staffing. So we'll keep an eye on that for you. We've had a lot of surveys recently. As I mentioned, I had a issue with one of our most recent surveys where the timeout wasn't perfect, but that was a wonderful experience. The surveyor was fantastic. She was very educational. The organization's director of nursing and the administrator are both brand new, so they had a lot of questions. They had a lot of learning to do from a surveyor. I mean, obviously they can get stuff from us, but it's really good, to be kind of under fire and, get that one-on-one feedback from a surveyor doing a real live survey.
Yes.
So it was a very favorable experience to the organization. They did very well. There was no condition level citations, and they'll have a nice report. Despite having a timeout that was less than perfect, let's put it that way. Yeah. Unfortunately, just before that, we had a really, unfortunately, unpleasant experience with this survey, and we're going to talk about that a little bit later. So just kind of how to handle that situation. And while we're on the subject of surveys, a couple other things have been coming up recently, and that is there always has been a requirement for organizations that fall under the OSHA requirements to have a chemical risk assessment. And if you're not familiar with what a chemical risk assessment is, you might want to just Google it and see some examples of the forms that you would use for this. But basically, you're analyzing or identifying all the chemicals that you use in the organization and what you would do to protect your employees against any exposure to those chemicals. So this is a new line item in HHHC surveys, which is why we're starting to see it pop up more. So in addition to all those other risk assessments that we're doing now, and we probably could do an entire podcast on risk assessments. I know we did talk about them during a previous podcast, but it might be a good focus segment for us at some point.
Yeah, delving into each one.
Yeah.
What is required.
Absolutely. So definitely, if you have not done a chemical risk assessment, learn about it. There's a lot of resources available on the OSHA website, and there's some examples of risk assessments just by Googling it. And the second thing that has popping up a lot lately is the inappropriate use of the term MAC, or monitored anesthesia care. The term MAC is actually a billing term. It's not it doesn't identify a level of anesthesia, and it's no longer an acceptable term to be used in your medical records or in your consent forms, for example. So you need to start replacing that term monitored anesthesia care, or MAC, with the appropriate level of anesthesia, such as minimal, moderate, deep, or general anesthesia. And of course, as we've talked about before, make sure that your anesthesia consent includes what level of anesthesia is anticipated. So look through all of your documents, especially your consents and your anesthesia forms, and make sure that you start to remove or do remove all of those references to MAC. And
next week, I think 13 or 14 of us are heading off to the New York State Annual Conference.
Yep. It is the largest conference that we all attend, mainly because we have so many clients in New York, and because since many of our employees are in New York, it's a lot easier for them to get to it. So all of our New York State clients will be invited or have been invited to a special meeting there. We have a pre-conference, which is put on by the ASC Podcast, as well as the conference, which continues Thursday and Friday of next week. So it's all very exciting. We're going to do a special episode, which will be kind of a large episode. We have quite a number of interviews scheduled for that. So keep an eye out for that, especially if you're from the state of New York. And as we all know, there's always interviews that we get out of this that we take to our national audience also. So we're very excited about that. So let's go into some recent news. I saw a press release recently from the Blue Cross Blue Shield Association. It was dated September 14th, 2023. And the title was Costs for Common Healthcare Procedures Significantly Higher When Performed in Hospital Outpatient Departments. Mm-hmm. We'll provide a link to the press release for this, but it noted a couple things that I think are very interesting to us because we, of course, have been saying all along that surgery centers, ASCs, are much cheaper than hospital outpatient departments. But here is the Blue Cross Blue Shield Association really giving some data, and this is what they said in that press release. And again, I'll provide a link to it. Mm-hmm. HOPDs can charge nearly 60% more for procedures than ASCs and doctors' offices, according to claims data analyzed by Blue Health Intelligence, which is a registered trademark of the Blue Cross Blue Shield Association. And the Senior Vice President of Policy and Advocacy, David Merritt, said, he's quoted as saying the following: "The cost of a procedure shouldn't be determined by the setting where the care is delivered. Lowering the cost of care regardless of the site is common sense. Our analysis shows that site-neutral legislation would save our patients, businesses, and taxpayers nearly $500 billion. That's $500 billion, $500 billion over 10 years. And we look forward to continuing our work with Congress to protect patients from these higher costs." So in a previous episode, we did indeed talk about price transparency. And here's yet another article, another take on it recently. And Sue, why don't you mention some of the price differences they noted?
Okay, so the price differences noted in 2022 for common procedures based on setting where colonoscopy screening cost 32% more in an HOPD than in an ASC and double the cost compared to when they were performed in a doctor's office. Diagnostic colonoscopies cost 58% more in an HOPD than in an ASC and more than double the cost compared to when they were performed in a doctor's office. And cataract surgery cost 56% more in an HOPD than in an ASC, and ear tympanostomies cost 52% more in an HOPD than in an ASC. So that's pretty major.
It is. And of course, we talked about there are reasons, and I do understand and support hospitals getting paid more, which is not what the Blue Cross Blue Shield organization is advocating here, or the American Hospital Association, of course, is on the opposite side of this, saying that we should be paid this amount more. So this is going to be an interesting battle as we move forward here. And as I mentioned, previously, one of the concerns I have about this is that price differential is our competitive advantage. If indeed all the prices are brought down to what we're reimbursed, then indeed we don't have that advantage anymore. Everybody would get paid the same amount.
Yeah, but we would still have the advantage of people being more concerned about going to a hospital because of all the illnesses around there, and I think just more ease with scheduling and getting into a smaller place rather than having to walk through a big hospital to get stuff done. So I still think there's going to be advantages, but I know what you're saying.
Yeah, well, when you mentioned ear tympanostomies, that one struck me because those are on little kids. Almost always they're done on babies or toddlers. And who wants to drag a toddler or a baby into a hospital environment? You want to have a more home-like environment where it's going to be far less scary. So we'll keep an eye on what's going on with this whole topic of price transparency. So there was an article in the Ophthalmology Times August 2023 issue, August 25th, 2023, by Michael Shumsky. I hope I pronounced that properly. He's an MD, MSc. And the title of it was, "Is Office-Based Surgery a Harbinger of Things to Come for Ophthalmology?" And I've been talking about this actually, and by the way, there's a link to this in our show notes, but I've been talking about this recently, how I really do anticipate that cataract surgery is eventually going to be moving to an office setting, into the office-based surgery setting. And it was just interesting to see this article come out. And he concluded here, again, in this article in Ophthalmology Times, lens surgery can be performed just as safely in an OBS suite as in an ASC, according to the literature. Frankly, in my experience, he said, By granting more control over the entire surgical process, an OBS suite makes it even safer. An added bonus to OBS is that it has been a practice builder. I can offer an elevated patient experience and have more OR time available to accommodate my schedule and growing practice. And then he went on to say, as far as reimbursement, though coding and billing are different from the process associated with an ASC reimbursement, the doctors are compensated at approximately the same rate. In other words, they don't get any additional reimbursement for doing the procedure in their office. But reimbursement policies do vary depending upon where you're located. And some private insurers are starting to recognize OBSs and might be willing to reimburse an OBS for the technical or the facility component, even commercial carriers that offer a Medicare Advantage program. But currently, Medicare only pays facility fees to an HOPD or an ASC. And remember that, cataract surgery is the most commonly performed ASC procedure for Medicare. And given the potential savings to the Medicare program, it really is likely that there will be a push to move these procedures to the OBS setting. I asked the question again here, what does it mean for the future of ASCs that concentrate on ophthalmology? We really need, as an industry, to keep an eye on this and the potential competitive situation, given that this is the most common procedure. To move all of those procedures out of ASCs would provide an opportunity, obviously, to do other procedures there, but it could have an impact on ASCs and perhaps may even result in the closure of many of the ASCs that are out there now. Mm-hmm. And of course, we also need to keep an eye on what insurance companies are going to do with regard to reimbursement. If they do, provide reimbursement for the physicians to do it in their office for some number lower than the technical component that is being paid to the ASC, that would certainly provide the incentive to the doctors to do it in their office, as well as the savings to the Medicare program, and even private insurers for doing those procedures outside of an ASC. So we got to keep a very close eye on that one as time goes on. And then I saw an excellent article in Outpatient Surgery magazine in August 4th, 2023. And again, I'll provide a link to this. And this was entitled The Essentials of Instrument Tray Management. And this was by Casey Czarnowski. She's a BA, CRCST, CSPDT, CISC. Obviously, somebody that's very knowledgeable about infection control and sterile processing. Mm-hmm. And I hope I didn't pronounce her name incorrectly. I'm sorry, Casey, if I did. I'll provide a link to the article here. And in this article, she asked the question, how many of the instruments and entire instrument trays that arrive in your operating rooms and procedure rooms throughout the day are actually necessary? And she suggested that paring down your sets can save the center time, money, and resources while keeping surgeons satisfied and patients safe. Now, I don't have a lot of experience in this soup. Mm-hmm. But it does seem to me that I would bet that, given we try to all of this, the standardization we have might get to the point where we try to create trays in the operating room that meet everybody's requirements, yes. And then in the process probably don't spend a lot of time looking at those things that are, just like put in there once, in a blue moon.
And you're having to continually either
reprocess them. And there's you're right, and there's two dangers to that. One is, first of all, the amount of time the staff is taking, the amount of resources it's taking to re-sterilize that, as well as potentially limiting the life of an instrument that is actually not used that frequently, and you're just constantly re-sterilizing it. So from the writer's perspective, here is what you need to do to better ensure you accomplish the mission of trying to improve the efficiency of your SPD department. And this is what they said: achieve comprehensive buy-in, beginning with SPD leaders, techs, and nurses. In other words, bring everybody together and say, this is something we want to do. We want to reduce the number of trays that are being brought in. And I think everybody in that process is going to be interested. Nurses don't want to be carrying any more trays or opening more trays and then closing those trays and then moving those trays later than they absolutely have to. And of course, the SPD people don't want to have to do any more processing than is required. And considering that this project is likely to take months or even a year, that's crucial for success to bring everybody together. You need to find one or two of your surgeons who will champion the project, which can be very difficult, of course, because surgeons are creatures of habit and they want to have every base covered during the procedure. They're not going to want to take any risk that something they need is not going to be in that precious tray. And then the next key to success is to perform a pilot project with your surgeon champions. Don't try to do it with every surgeon all at once. Just try to find start with those surgeon champions and start, paring down what is being brought into the room.
So she's suggesting the different surgeons have sort of like a preference list or for different procedures maybe, and just make sure you
Right.
try to stick with what you think they'll need.
Yeah, exactly. I think there's always been a thought that I'm just going to throw everything into that tray that they could possibly need. And maybe two things might happen. First of all, you're not always revising those preference cards on a frequent basis. Maybe it's been a preference card that's all yellow if it's actually paper, and they've never changed it. And maybe that doctor just doesn't even use, maybe even half of the instruments that come in that tray that frequently. And I think another part of this is, let's pare it down to what's used in 90% of the procedures, and maybe have another tray on standby that can be brought in quickly if you need something additional. And then, after you've done this, of course, consider how to roll it out to other doctors by showing the early successes with those surgeon champions.
Probably much easier to get the rest of them to buy in once they start seeing that it's working.
That's right, and that there's, the doctor, the champions are showing that they, that they could do it, that they were not inconvenienced, et cetera. So I thought it was just an interesting perspective, and it might even save some space in the operating rooms, or for that matter, the storage of your in your sterile processing. I did want to talk about a couple recent experiences. We kind of alluded to this in the beginning of the episode, but we did have a survey experience that was not so great. Now, first of all, I didn't need to point out that there were no condition level citations. There really were no major findings during the survey. But unfortunately, there were two surveyors, and one in particular was particularly rude and abrasive, and the other one I think was uncomfortable with the situation, but wasn't any more consultative. I mean, there was no consultation going on. There was no education going on. These were accreditation surveyors, so it's not like the state where, I think it's more frequent that you do run into surveyors that might be a little bit more, matter of fact. But I'm an accreditation surveyor. We're taught right from the very beginning that we're there on a consultative basis. And of course, we have to identify problems. We have to cite situations that need to be, corrected. And we need to write a very comprehensive report that identifies what we found and what we felt about the organization. But unfortunately, I don't find that there's ever a need to be rude and abrasive and during a survey, and it was very disappointing, so much so that I had to report it to the accreditation organization. And unfortunately, also during this particular survey, one of the surveyors actually disclosed private information about one of the health situations of one of the employees, and that had to be reported immediately. So you should never, surveyors should never be disclosing anything from a HIPAA standpoint that, it's the same rules there as you have with the nurses, your staff about anything else that's going on. So it was a very tough week for us because we were very disappointed. We really, I got to say, I don't think I've had an experience like that in years. I've seen it before, and especially way back in my beginning part of my career, but there's so much effort being taken now to train surveyors to be consultative, to be educational, to make the survey experience a real learning experience for the organization. And nobody in that organization felt that they learned anything from that survey, which is very disappointing. And then I was not there. We as an organization decided to kind of stay away from this because we didn't want to add any fuel to the fire. So the exit conference was without us, and during the exit conference, I asked, the people that were at the exit conference, did they say anything nice about the organization? And that was really disappointing. They actually said nothing nice about the organization at all.
And again, it's a good center.
It's actually one of our better centers here in terms of its compliance. The organization has top-notch leadership. There were no major citations out there. They were just very rude and very they were identifying things that were not really standards.
Yeah, that's the thing. I don't think nobody expects people to overlook things that are problems, but there's a way of conveying it and trying to improve the care, without being rude. And that really wasn't even the case here. They were just really being very abrasive and I don't know what was going on there, but it wasn't helpful at all.
Right. Maybe they were just having a bad week. I don't know. And I did want to mention one example during the survey. The surveyors were looking at the drills, and they noted that the drills had a list of all the attendees that was typed into the report. And the surveyors came back and said, oh, no, you can't do that. You have to have the signatures of the attendees. The organization said, well, I don't see that. I did not know that. And now, at this point, Sue, they were so gun shy, I think, that they did not want to really confront them. And that might have been the appropriate way. But my feeling when something like that happens is you go back to them and you say, you just kindly ask them if they can show you in the standard that would be the requirement. And trust me, there is no standard that requires to have a signature of the attendees there.
And again, you say it kindly. You could say, so that I can use this in my re-education of staff. Right. Just let me see the standard. And always remember, if that doesn't work, that no matter what they say, if they go back to write the report and there isn't a standard for it, you likely won't get cited because they'll have nothing to back it up.
We don't have the results of this survey yet, and I suspect a lot of those things, there were actually quite a number of situations very similar to that, that I doubt very much will show up in the actual report because the review, function within that accreditation organization won't allow it to get through.
So you don't have to. You never really want to argue.
That's true. So let's just talk a little bit about what you really want to do when you're dealing with a difficult surveyor. First of all, don't return their rudeness with rudeness. Be nice, consoling to them, thank them for their feedback, and recognize that when the survey comes back, if you can't convince them that indeed you were meeting the standards, or if you find yourself in a situation where you're arguing with them as to what the standard is, the best thing to do is actually wait for the survey report to come out. First of all, to see if it actually shows up in the survey report, and then if it does, then you can argue it at that point and just point out that where you were correct.
And the report will have the standard cited there, so it has to be a standard, or they really can't.
They shouldn't cite it, right? Yes. That's correct. And then lastly, I just want to make sure that you take the opportunity to evaluate the surveyors and the survey organization there by providing feedback. And if there's a serious violation like this HIPAA violation, report it immediately to the accrediting organization so that they can take appropriate action as quickly as they can. But, I'll say, I haven't had an evaluation. I've been working as an accrediting, as a surveyor for, about 23 years, and I haven't had a survey performed on me or, feedback for me for over 3 years. Now, I'm thinking it's because I haven't really gotten anybody angry during a survey, but who knows? But on the other side, I'd like to have some positive, and, I'd like to have some, some comments or some suggestions as to how I can be a better surveyor.
I bet people are a little nervous, too, though, because they're afraid if they say anything wrong, then the next time a surveyor comes out. But I don't think that's the case.
No, and they're not allowed to, to have a connection between that. That being said, though, accrediting organizations do know that if if there was a bad survey and the organization complains, then there's probably a reason that they complained about that. And I've seen that in my career where surveyors have been hammered by the organization, and it turned out because they were doing their job. They were identifying things that needed to be fixed, and the organization was angry that they were doing that. But that's certainly not the situation here. So I hope this never happens to you. But every survey is different. Every surveyor. It comes from a different, a place, and you just never know what you're going to run into. I think it's much more likely you're going to run into a rude surveyor or difficult surveyor during a state survey. But this was very surprising to me to see it in one of the accreditation organizations. I did also want to mention during our Saturday patron drop-in session this last Saturday, there was a discussion about H&Ps, and we're going to have a very extensive conversation about this in the future. But we know that, the H&P conditions for coverage and interpreted guidelines have changed. Now, fortunately, there has not been a mad rush to eliminate H&Ps, and nor should you, because the interpreted guidelines are very specific about what you need to do in order to change that 30-day rule that had been in place for a long time. But the situation that we ran into during the Saturday drop-in, or the question was asked, is the H&P had been done in the office by a nurse practitioner prior to the date of service, and it was within 30 days. And on the day of surgery, the doctor didn't want to do the update prior to the patient rolling into the operating room. In other words, he was just kind of looking at the patient when the patient came in and then just signing off saying that he had done an update. But he really didn't do an update. And, of course, it's too late to do a history and physical when that patient is in the operating room, because at that point you're ready to start doing things. So if that update needs to be done, by a physician prior to them going into the operating room, and it needs to be documented as such. Make sure that history and physical is done within 30 days and includes a complete ROS or review of systems. And then on the day of surgery, it's updated, which would also include all of those systems too, and a heart and lung evaluation. And as I said, we'll have a much more comprehensive discussion about this in the future, because I know this is going to be a very hot topic. So, Sue, as we discussed earlier, we had a retreat in September, the beginning of September, for all of our staff from Ambulatory Healthcare Strategies. We also brought together some of the staff all of the staff from the ASC Podcast with John Goehle. And we sat around a table. Now, the recording that you're going to hear isn't perfect. It unfortunately is in our big studio and also remotely with all of the people that were joining from their other locations. But I think you can hear pretty well the discussion. And again, there was a good conversation about the early years of the podcast. So let's take a short break. And when we come back, we'll have this interview with the staff of the ASC Podcast and our previous co-hosts, as well as the staff of Ambulatory Healthcare Strategies. As a leader in the ambulatory surgery industry, you already know that the ASC Podcast with John Goehle is your ultimate free resource for staying updated with the latest news and information while ensuring your organization maintains regulatory and accreditation compliance. But did you know that we have 2 membership programs on our partner website, ASC Central, that can take your organization to the next level? For just $25 a month, our patron program will unlock a host of amazing benefits. Enjoy regular Zoom meetings with our hosts and special guests, access to recorded conferences like our credentialing seminar, Conditions for Coverage Conference, Medical Director Conference, and our most recent 2-day multi-state conference. The patron program also offers a comprehensive database of policies, forms, drills, example minutes, and other invaluable resources to optimize your center's operations. For those centers that want even more, our new ASC Central Premium Access Plan offers a variety of online services to its members. The benefits include access to a wide range of services, including all of the benefits of the patron program, unlimited access to our popular boot camps, the ASC industry's most comprehensive training for ASC leadership. Members can attend any number of the ASC Administrator boot camps and ASC Director of Nursing boot camps and can listen to the recordings throughout their membership. It also includes unlimited access to the industry's most comprehensive infection control training, designed for infection control coordinators and those that wish to take the Certified Ambulatory Surgery Center Infection Preventionist exam. And the program also includes up to 5 hours of private consultations by Zoom. For more information about these 2 programs, visit our website at ascpodcast.com or click on the links in the show notes. So I'm here at the fall 2023. I really shouldn't be calling this fall 2023 because it is in September. It's still technically summer, but it's our Ambulatory Healthcare Strategies retreat. And we're reflecting on the past 6 years of the ASC Podcast with John Goehle. We are, of course, celebrating our 200th anniversary with this episode. And I thought we would invite back some of the people that were very instrumental in the very beginning of the podcast, just talk a little bit about that history. So I have with me Judy D'Ambrosio, who was our first co-host. Say something, Judy, just so I can make sure your microphone's working there.
Did we do this already?
We did, but I want to make sure, because you just aimed your microphone away from you yet again.
I tend to do that.
I know.
I'm back. I'm here to do it again. Just once.
So Judy was by the way, I had to go back through the history to find out all these dates. So you were the co-host from January through approximately April of 2018. And then I also have with me Jenna Alvarez, who was not the official co-host, but she was involved in the first 4 or 5 months of the podcast, mainly because she was living with us as she was looking for a house. Looking for an apartment at that point, and then looking for a house later. So she was actually living in what is now Studio 2 and Studio 1 in the house here. So she was easy. She was an easy target to pull upstairs and do our weekly podcast. So say hi, Jenna.
Hi, everyone.
And then also with me is Sue Cronkite, who became the co-host in it was somewhere around May or June of 2018. And then, of course, she has been the co-host since then. Say hi.
Everybody.
Sue and I are sharing a microphone, and let's just go through a little bit of history here. I'll remind people of this because it is kind of interesting. So Jenna, you are the reason this podcast exists, because Jenna and I were doing some work in outside of Boston.
Jenna was bored in the car.
But Jenna was bored in the car, and she was driving back with me, and she said, "Can I listen to a podcast?" I said, "What's podcast?" I really don't care. Just listen to whatever you want. And Jenna, do you remember the podcast you were listening to? It probably doesn't really matter, but
I don't know. Back then, it might have all of the stuff you should know or stuff you missed in history class.
In history, and I'm thinking to myself, I asked Jenna, what is a podcast, and how does this work? And she said, well, there's podcasts that have like 3 people that listen to it, and podcasts that have 3,000 people. And bells started going off. And I'm thinking to myself, I always wanted to be a radio host. I'm kidding. But, but the thought was there that, maybe we should, talk a little bit about what ambulatory surgery centers do. We know that we can't have a weekly radio program because, there aren't that many surgery centers out there to justify it. And that was the genesis. So you're to blame for the existence of the podcast. And I thank you for that.
Started a whole trend in the industry.
You did. And of course, there have been other podcasts that have come and gone over time. And we are the longest running podcast, of course, out there. And we're very proud of that. And we now celebrate our 200th anniversary. So I want to take you back, my friends here, to those early days. Remember? It's funny, Judy, I listened this morning to the first episode and talk a little bit about, what it was like then and the microphones and all that.
The idea that neither of us had any idea what we were doing. Didn't know how the microphone worked. Really didn't know if we were recording or not.
Wasn't there a skit involved?
Yeah,
there was
we thought that we had to be entertaining. So we wrote scripts for what to say and little skits. But we thought we rocked.
Yeah.
We thought we were awesome. But it was awful. It was awful. But go back. If you're a listener, go on back to 1 and just laugh.
Well, and so I'm listening to this and I say, boy, Judy sounds really good. The microphone, because I knew at the time that I had bought these microphones off the internet for $35. I mean, which is a lot of money for a microphone, by the way, back in 2018. And I'm thinking, this is a fancy microphone. It plugs into your USB port. This is going to be fantastic. I plugged these things in, I don't know. We spent hours getting them to work. And I'm listening to this first podcast and you sounded great. You could barely hear me on my microphone. So whatever we had done, you had gotten the better microphone because we had different microphones that were playing around with. Yeah. And, that's how we started. We started doing the podcast in the dining room upstairs. We're now in Studio 2 downstairs. And we did in the dining room. I'd have to set up all of the microphones, all of the stands. And, when I think about it, it wasn't a lot of money. I mean, it seemed like a lot of money at the time. And by the way, we're actually in Studio 2 right now. We're using the boom microphones on our tables here that we used in the very beginning, but we'd have to set them up every single day. The boom microphone that I have in front of me, Judy's looking around saying, what the heck are you talking about?
None of these look familiar, but you're right. Okay.
But those were $39 microphones. Today, the studio, we're actually not in the main studio right now. We're in Studio 2. But those microphones that we're using in the main studio now cost $600 each.
Oh my!
And I mean, you can tell the difference, with them. But boy, have we come a long way. So it has truly been a pleasure doing this. But in the beginning, as you said, Judy, we had a lot of fun. I mean, we did the skits, and some of them were pretty corny. I mean, they definitely were corny, and we didn't quite figure out the whole thing that. We started and as a matter of fact, when I was listening to it, you and I discussed what our goals were, and it's interesting that it's pretty much the same things today, that we wanted to educate people on compliance and being ready for surveys, answer questions, because we thought at that time people would be sending all kinds of questions. So here's a little secret. How many questions did we receive in the first 3 months?
I don't think anybody sent us.
No, nobody sent us questions, but how many questions did we answer live on the podcast? You might remember you wrote the questions.
Oh.
Yeah, we created questions.
Yeah, well,
and we pretended they came from our listeners.
I think they came from our clients.
They came from our clients, yeah.
They just didn't know that they were going to be used
on a podcast.
Did you just pretend that we got them? Like
we did. Yeah.
We have 6 questions today, as if they
we won't be able to answer 2.
Yeah.
But that's the way it was in the beginning. A little bit also is that the official date was January 1st of 2018. So the first episode was dated January 1st, 18. It was actually published in March because the professionals that tell you how to do podcasts said what you need to do is you need to have like 3 months of podcasts in the can before you start publishing. I don't remember, we used a media consultant at the time and said, you want to, you want to come out. You don't want to just have the only podcast, episode out there. You want to like show that.
I have a couple.
Yeah. Right. You're a real, player in the podcast industry. So, we did that. We published, I think, about 6 or 7 at the same time in March of 2018. And here we are 5.5 years later. And then, we had a retreat in June of 2018, at which point we decided that it was becoming difficult for ambulatory healthcare strategies to provide the resources for the podcast. And at that point, we separated ambulatory healthcare strategies and the podcast itself. So they're, the 2 separate entities. They have separate staff. We continue to be a sponsor of the podcast at that point. And of course, that's the way we've been, for the 5 years since then. Then 2019 came and Jenna had moved out. She had gotten her own apartment at that point. Her sister had moved in between that time frame, and then she moved out in November of 2019. And we built the new studio, which was in what would have been your bedroom down in the in-law apartment down here, and turned it into. We bought some used computers, some relatively inexpensive microphones, set it up as an audio studio, bought a lot of used audio equipment, and set this up and started recording down there. And it worked very well for a while. But keep in mind, this was in November of 2019. And then comes March of 2020. Suddenly, the whole world changed, as we all know, and there was this huge demand. We, in the space of a short period of time, Jenny, you remember this? There's actually a couple of videos that we posted on YouTube at the time, where we went live. We learned how to go live on YouTube. We learned how to go live with the podcast, and we published. Over a period of about 3 months, we were going, sometimes 2 to 3 times a week. Sometimes live, sometimes recorded, doing the podcast. And that's when our listenership, really moved up dramatically. And it was quite an exciting time. But, if you have a chance, go to YouTube and watch the video of us getting ready in the second week of March to do a live podcast. Because we recorded it. We didn't do any editing or anything like that. And you can see Jen and myself and Sue, and I can't remember who else was in that video.
Like March was it was the Friday, right? When everything, I think everything shut down after that.
That's right, exactly. And we were all trying to figure out what to do. And it's funny because I'm watching and I'm thinking, I'm almost teary-eyed think about this, because we didn't know what was happening at that time, but we were all scared. I mean, it was visible in this video what was happening. And, if you look at it in perspective of today, and then you listen to the conversation about, well, we don't know what's going to happen, it's an interesting history lesson to go back and look at that. As you can tell, I'm kind of teary-eyed, to reflect on, the last 5.5 years. It is very nostalgic here. So what happened is then we all discovered Zoom. And we converted the studio. That was the first of many revisions to the studio. Since then, we got rid of all of our Windows computers, bought Macintoshes, used Macintoshes. We upgraded and included new microphones, and relatively inexpensive video equipment, and the rest is history. Really, over that time, we've renovated the studio approximately 3 times. Matter of fact, we're not in the studio right now because the studio is going through yet another upgrade as we move to an even higher level of equipment. By the way, the equipment that we're putting into it, Judy, you'll appreciate, we're actually using movie quality recording equipment, so we can actually create a full blown 2-hour movie if we
I'm excited when we start.
Yeah, exactly. So here we are in with our 200th episode over 5.5 years. Here's some statistics that you might find interesting. We've had 54,000 downloads, 219 current followers. Doesn't really mean much because most of our listeners actually don't hit that subscribe button. Please hit that subscribe button. It helps us. We have between 500 and 1,000 downloads per month, depending upon how many episodes we publish that month. And that number is important to understand. When you consider that there are 6,000 surgery centers in the country, that's more than 10% of the population is listening to us on a regular basis every month. We also know that our listeners generally do not, we might have 100 listeners within the first week or 2 of the episode. So many of you apparently have other things to do with your time, and sometimes you do not listen to us right away. But we do find that over time you eventually do tune in. So that's how we end up with that that close to 400, 500 episodes. We are still shocked. I still go around to conferences, and I'm still shocked when I have to hand out a card and tell people, about the podcast and about the existence. There are still people out there that don't know and or don't understand that this is a free resource that we offer. But we love listening to our listeners. We love meeting them during these things. I know, Judy, you still talk about how people come up. I recognize your voice.
Wait, you were there in the beginning.
That's right.
Yes.
And of course, Sue now, her voice is, so I do have to say something as I'm sitting next to Sue here. I'm going to embarrass her for a second. We all know Sue. She's an introvert. If you don't know that, you can't tell that by listening to her. But Sue's an introvert. She does not generally like to talk. As a matter of fact, she's not talking right now, and I'll be sleeping on a couch tonight, but just by putting her through this. But she's done an incredible job as the co-host, and has really been able. She does a lot of our research, if not most of our research, really for the news on a regular basis. And I just want to thank you for taking on that very difficult job of keeping me in line. And she does all the editing too.
Yes, the editing is the big thing. And I'll never give that up, because then I can cut out all the things that I say that I think, why did I say that? That didn't make sense.
So, but I do want to thank Jenna and Judy, and of course Sue, for all of the incredible work that you've done to get us to this point today. And then I would just like to say that, keep in mind that we do have the patron member program. We currently have approximately 250 patron members. And that number does continue to grow. It is in $25 a month for access to a weekly drop-in session where we give you an opportunity, usually weekly, it's not every week. We give you an opportunity to kind of join us by Zoom and ask whatever questions. It's becoming a self-help group, isn't it? Lori's with us here, who's one of our regular surveyors that show up on that weekly session. So do consider becoming a patron member to help support the podcast. You have access to us. You have access to the weekly drop-in sessions on Zoom. You have access to a very large database. And starting in February, we introduced what's called the Premium Access Program, which provides access not only to all the resources that you have as a patron, but also unlimited access to many of our educational programs, including our Director of Nursing and Administrators Bootcamp. For more information about that, visit asc-central.com. So we are here with the Ambulatory Healthcare Strategies team for our fall 2023 retreat. It's here in Spencerport, New York, and we have our largest crowd yet, and our newest member, Christina Norman. Waving is not going to do any good, Christina. So just say hi to our crowd here.
Hi, everybody.
Christina has actually been interviewed, on the podcast over time, and she has been a longtime listener and a very good friend of ours. She knows everybody on the team, and we're so glad to have you on board. What week are you on now with Ambulatory?
I'm almost to my second month.
Oh, wow.
Oh, wow.
Heavens. I was thinking 3 or 4 weeks.
You've dealt with me for that long.
And now, just to remind our listeners, we do get together on a semi-annual basis. We're a little bit behind right now. As a retreat, twice a year, we do a retreat. to talk about things that are going on in our company, in the industry, and to set goals and objectives for the organization over the next, 6 months or, actually into the future. So I have everybody here. We have live microphones around. So you're going to hear coughs. You're going to hear, bumps and things like that. Our equipment is a little bit better right now. I know you love turning your microphones away from each other, but for our listeners' sake, please do aim the microphones toward you when I ask you a question. What I wanted to do is I wanted to talk through some of the big issues that we talked about here during our 3-day retreat. Because each of them, we've chosen these topics because they have been things that we are noticing with our clients. There's major issues, and we know that they are an industry issue also. And we're going to start with the whole issue of education. We know that right now, education is an extremely important part. We're hiring a lot of people that are not necessarily well trained in ambulatory surgery centers. We used to, it used to be the day. So, Lori, you and I have been in the industry longer than we care to admit. But in the beginning, we just could not hire staff members that really didn't have experience, right? You're not going to hire somebody fresh out of college. You were getting people from, the hospitals in particular, because there's really no other place that they would come to you. But do we have that luxury anymore?
Oh, no,
Yeah.
definitely not. That's long gone.
Right.
That's why you have to be very diligent with the staff that you have so that they become the teachers.
Right. And that gets to the point that we're having here now is that, sometimes we don't take our education program seriously. I'm going to look at Judy, who is, has been our director of educational services for a while. And she's kind of actually moving out of that. We're going to talk about that in a bit with her movement into the medical records area. But Judy, you developed a lot of our educational programs over the last about 8 years now, I think.
Yeah.
And you make that expectation that people are actually listening to them. But what is some of the things that we have learned, unfortunately, over time?
Well, I'll tell you that I very much more enjoyed being in person and talking to a room full of people than I did making binders and sending them out. And then I thought, well, maybe we can, meet halfway and I'll record it. No, none of it is the same as
in person.
But I think COVID really put the kibosh on that for everybody. We just don't travel. We don't do this. So we've struggled, I think. I feel as if we've struggled to make a product that did the job.
Yeah.
But did it a little better than anybody else did the job, which is always our expectation. We're going to be just a little better than everybody else. So it really has been a struggle to make this product what I think you, John, and I want it to be. And then we're finding that nothing is going to be like it used to be, where I would go and sit and I'd have 35, 40 people in a room and get their questions right then.
Yeah.
And be able to clarify to the quizzical look on the face of the person in the third row that you can see because you're there. And that just doesn't happen anymore.
Yeah, and I think we also know that there are online educational programs out there that provide generic training. And some surgery centers say, they go to a surveyor and say, hey, don't worry, we have all this training. Everybody does it online. And some surveyors look at it and say, that's great. But what's the problem with that?
Well, because it's exactly what you said it was. Generic.
Right.
It's not going to walk you through your emergency preparedness plan. It's not going to talk you through your quality improvement plan. And it's fine. I mean, it's a product, available and used quite a little bit, but, generic, you get exactly what you're paying for with that. You get exactly out of it what you put into it.
So Jenna, I'm looking at you now because we know that one of the challenges that we have with education is that first of all, there's so much pressure for our staff, for the staff in the surgery centers to get out there and get to work. You hire somebody on Monday, right? You hire them on Monday and you want them working on Tuesday. And they maybe they work for 5 years, maybe they work for 20 years in a surgery center, and you just say, something, they really don't need to go through this training program. But we know we have a problem. Jenna, you have a story, don't you?
Yep. We had a center that we helped reopen recently, and they hired a whole new staff. We rushed to get them a beautiful policy manual, beautiful education program. Thank you, Judy. Got it all in place. And surveyor showed up unexpectedly early after they had reopened and looked at all the education and said, this education looks great. We love it. None of the staff knows anything about the emergency preparedness plan.
Yeah.
And we're citing you for not properly training your staff so we had all the documentation that they had done the education, but it was clear upon interviewing the staff that they
had not
actually done the education.
And to that point, I'm looking again at Lori, because when we go in and we talk to people there, it becomes apparent. We do look at the educational program. We look at the sign-offs they have, but how apparent is it when you get in there that they may not have actually done the training or done the specific training for that surgery center?
It's extremely evident, whether it's something like the emergency preparedness or sharp safety, or which is universal.
Right.
And if it's still not being complied with, or medication safety or infection control, or documentation, we see it all the time.
Yeah. And you have to, so you can use these online educational programs, that's acceptable. But more importantly, I think I've estimated that's about a third maybe of the total education an organization has to have. You're going to have to train them on infection control, example, Lori. You're going to have to and train them on peer review. You're going to have to train them on disasters. Jenna was talking about the disaster preparedness, the fire safety, because, no organization that, lives up in the cloud is going to be able to tell you where the exits, where the air, I was going to say air conditioners, where the fire extinguishers are in your organization. You need to train them specifically. And we as surveyors, Lori and myself, are going to be walking around and asking questions of your staff. And if we get an answer that runs contrary, the next question we're going to ask is, do you remember your training program? Tell me a little bit about it. And to your point, Jenna, if they come back and, it's apparent that they signed off on it, but they actually didn't pay attention to it, you're going to run into a problem. So the big takeaway on the education side is it is important that you take education seriously. And it's not just because you want to pass a survey, right? And we actually spent quite a bit of time as a team here talking about it's not just because of that. It's the right thing to do. You want to have people prepared. You want to be able to be prepared to handle an emergency. God forbid something happens. You don't want them working off of generic training. You want them to know exactly what they need to get into. So, make sure your programs are well written. Make sure that they're specific to your organization. Make sure that they are delivered in such a way that you can get feedback from them to determine whether it was done appropriately, and be prepared for surveyors to ask those questions and be able to answer them. And when you find that your training has missed its target, when maybe you have an incident that occurs, you're going to want to make sure you do the retraining at the proper time. I don't have this in the script here, but I'm looking at Christina for a second. Christina is the one that's most recently come out of administration. And, Christina, I just want to finish by, I'm sure you have stories about re-education that you've had to do over time. Can you talk a little bit about some of the most recent challenges that you've had where you've had to do like in services in order to get people ready?
Yeah, I think it goes back to, onboarding staff that hasn't necessarily worked in an ASC before.
Yeah.
Having to change their mindset from hospital thinking to surgery center thinking.
Yeah.
And I think it's really important that when you have incidences such as, codes or anything like that, that you go back and you do a lot of retraining and rethinking with your staff, like what situations led up to that incident happening? What could we have done differently?
Right.
And not necessarily only do that when those incidents occur, but it's an ongoing thing.
Yeah.
Not just an annual thing. It should be a monthly thing.
Right. And by the way, I'm listening to you, Christina, you've done some public speaking. Can I ask the rest of the crowd here, do we have a good speaker here? I mean, she had no idea what question I was going to ask her. And was she able to answer that question well? So I think she's ready. Good job. Good job. See, now I've got everybody else in the room scared because they don't know if I'm going to ask them some oddball question. Next thing I want to talk about, which is an ongoing and increasing problem, and that is the responsible adult. Who wants to kind of paraphrase the description of a responsible adult and where that falls in?
I volunteered Donna.
Okay.
So every patient who is discharged from an ASC, who has had anesthesia of any type, needs to be escorted home by a responsible adult, meaning somebody 18 years or older who is able to make sure the patient gets home safely and stay with them, would be available for them for at least the next 24 hours. I think that there are people who show up and say they have an escort home and they don't. And then there are people who show up with their 16-year-old child who has a driver's permit and they say, my daughter's going to drive me home, and she is not a responsible adult. And that creates quite a bit of chaos for the ASC and a problem for the patient, because without that escort, they technically really cannot have their procedure done.
That's right. And there's been a lot of talk on the various channels out there, these question and answer channels out there that have been, talking about this, because I mean, this is a problem that predates COVID. I don't think COVID actually has had a huge impact on it. But what we find, especially in many of our urban areas, is that people might not necessarily have an escort available to them. They might not, they might live alone and they don't have anybody to take care of. Now, and the doctors inevitably say, I've got to take care of this patient. We understand that. We do understand that, that they need to have the procedure done, but we have to do it safely. So I'm going to look at you for a second, Lori, on this one, because, let's just talk about the patient safety issue, because you've had some very, you've run into this as a surveyor. And so I want you to describe one of those incidents where, the doctors allowed that patient to leave without, a proper escort, and it could have been a bad situation.
Well, you can be I was sitting in a lobby waiting to go into the administrator's office. So I was in the waiting room of the facility, and the facility had a lovely glass wall that led out into the hallway of the building with the elevator. And I watched this woman stagger in that lobby area and actually go into the glass wall, and then go back towards the elevator and trying to stabilize herself against the wall with one hand, pressing the button to leave. And she was a post-op patient. And that to me is very unsafe. And a similar thing, I was in a PACU area and I watched a patient get up from her bay and walk out of the center to a hallway to leave without a staff member in attendance.
Now, that happened to be a mock survey. What would you have done if you were actually, well, I mean, you can't call an immediate jeopardy on a mock survey, but if you had witnessed that as a surveyor?
If I witnessed that as a surveyor, I probably would call my lead team and describe what I saw and get direction from them, because I really felt that patient was not safe. And not knowing what's going to happen. And was she going downstairs to go into the street? Did she have a ride downstairs? And this was pre-COVID, I believe. So it was, there was plenty of people in the, or even if it was COVID, you don't let a patient go downstairs, in a multi-level building unattended, assuming that the ride is down there just because they said they were on a phone.
Right.
Because you're responsible when you're releasing that patient. It's kind of like the bartender. Last one that serves that drink, even if they only had one drink at your bar, but they had 12 before they got there, that last bartender is liable. So you need to think about the safety of the patient and the safety of the facility as well.
So I'm going to ask Kathy Foti actually to step in for a second here and talk a little bit. So we know one of the first things, Kathy, isn't it true that the first thing the doctors say when there's no escort, that says, well, there's a provision in the conditions for coverage that a doctor can exempt a patient from it, right? So you run into this a lot. So what happens, and describe what the problem is with that.
Well, my experience has been that doctors do try to find the loopholes in things. And in this particular case, a lot of it stems, I'll take, for example, a lot of my clients are eye clients. We have a lot of clinics out there that are eye clients. So you're looking at an aged population that has issues already. So when the doctor says, well, we can exempt them. We can, they don't have any relatives. They don't have friends. They're going to take a medical Uber. So the medical Uber will take care of them. That doesn't meet the requirements. You can't just automatically exempt, especially before the patient is even in your center.
Yeah.
So that, yes, is CMS a little bit vague? Yes, they're vague, but we, meaning ASCs, have to really, again, falling back to Lori, we have to protect those patients. And there have been incidences where these patients go home, whether they're on crutches, whether they, have a bandaged eye, whether they've had a block of some sort, with a medical Uber, but that medical Uber is only good to drive up to the driveway. And there have been incidences where these patients go into their house, fall, injure themselves, have to be transported to a hospital. Again, going back, it's going to lead your center to having risks. You're putting your center's risk. It's just going to bring it up.
That's right. Donna, you've had some situations recently where the doctors have wanted to get to Kathy's point, they wanted to exempt people automatically, or one of the most ridiculous situations I think we saw, they were having the patient sign an AMA against medical advice before the procedure occurred, knowing that that patient was going to have to go home without a responsible adult. Of course, you could talk for an hour about this. Try to meld that into only a couple minutes of how we responded to that and what we described the problem and the solution.
So we explained that the patient can sign out against medical advice before they even have a procedure, because the requirement is that every patient will go home with a responsible adult unless they've been exempted by a physician. So that was issue number one. Issue number two, they wanted the physician to be able to just exempt the patient because they didn't have a ride, and because there is not really clear guidance in the CMS regulations, they really were pretty sure they could do that. And the conversation we had following that was that you're not only putting the patient at risk and the center at risk, but the physicians who are actually providing the anesthesia and performing the surgery on the patient, knowing that the patient was going to leave the facility, get into an Uber or a taxi cab, or maybe into a city bus, go home and be alone for the next 24 hours. Everybody was at risk, from the patient to the facility to the anesthesiologist and the surgeon. I think, we explained all of that, and hopefully we'll be able to find another solution for that particular center, because they do have a larger number of patients who do not have support people. And, to Kathy's point, there are a lot of aged patients coming for their cataract surgery, and maybe they don't have any family members in the area, and they don't have anybody who can drive them home. And sadly, they do need their procedures. And it's not just the aged population. It's every surgery center deals with this at some point in time with some patient.
Jenna, you are the policy person on many of these things. So let's just briefly kind of talk about what we would expect to see in a policy, and what type of documentation you would see a physician sign off on, if they were actually going to exempt a patient, and what would that expectation be?
Well, usually the need for an escort is included in your patient rights and responsibilities.
Right.
That the patient should be receiving before they even getting to the center, so that they know what they know that that's one of their responsibilities. And then they're going to need to sign off on that when they get to the center. Depends on the center. Some centers specifically have a place to document
who the ride is going to be,
who the ride is, and a contact information. And then in terms of documentation, you would have in your discharge orders. Mm-hmm. And I have seen some centers that have specifically a box that they check, especially centers that do a lot of local cases, mm-hmm. That they'll say discharge with an escort or without an escort.
But there's a difference. Local cases don't require the escort unless the case that they had done could cause an impairment.
Right.
So,
for example, even if it was a local and your hands were disabled,
right.
But
if you were taking a lesion off my right cheek, whichever one you choose, I should be able to get home without an issue. When it comes to the documentation, I would recommend that a center speaks to their legal counsel or their malpractice provider to find out what they would expect to see a physician write in the documentation that would relieve him or her of responsibility.
And Yeah. And to your point, there's no way to completely get rid of the responsibility that physician is taking on when they exempt a patient from that. And that's an important point you need to make to your doctors. And by the way, I'll just mention this too. I'm often the one that's called in and then try to explain to the doctors why they can't exempt an entire population here, or what type of a document they have to do. And basically what I do is I give them a document that says I take full responsibility, for, this patient getting home. I've assessed the patient and they've recovered sufficiently from anesthesia to be able to make it home safely. There aren't many doctors that are going to want to sign that document knowing that they've just taken on that responsibility. So that's one way to get them to convince them that they probably shouldn't allow that. The best scenario is to get them on board, make sure the patient is well informed prior to surgery, enforce a couple times that the cases are canceled, especially if you do that. And if the word gets out to the GI community that you're going to cancel a case where you've just prepped, if you don't show up with your responsible adult, the word gets around and they find people. People find people to take them home.
Right.
There's going to be situations and where there's going to be a problem, and it's going to occur to all of us. But we have to minimize that possibility and make sure that we are always remembering the safety of the patient first.
Well, and that's where it comes to the leadership team of the center being able to have the power to enforce their own rules.
Right.
So they'll, whether it's the nurse director or the administrator or the business office manager, whoever's in charge of that patient when they walk in, that they know that they have the governing board behind them that allows them to say, I'm sorry, we can't do your surgery.
Right.
Because if they're not going to be backed, more than likely they're not going to start that process. So it's really important that everyone is on board with that,
Right.
In my opinion.
Well said. So again, one thing to make sure, just to finish this topic up, is that if you do exempt somebody from it, make sure that exemption is specific to the patient that you're exempting. It should be written in the progress notes, or if you have a separate document, however your forms are set up, but it needs to be specific to that patient and mention specifically why you're exempting that one patient. There should be, and it says right in the interpretive guidelines, there's no such thing as a global
Blanket statement?
Blanket exemption.
Right.
There's no
such thing as a blanket exemption. So,
the one thing that CMS, where CMS is never quick except with COVID in making changes, is that the 24 hours is not always realistic, because the high percentage of the patients are going back to work the next morning.
Mm-hmm.
So they're not home for 24 hours after their procedure with a responsible adult.
Yeah.
24 hours though isn't in the CMS.
It's in the old HHC requirement.
So that people are aware that it's not, that there isn't a time limit, but that,
right.
They make sure that they're, till they're safe.
Right. And that's a very good point. I mean, we found that many centers have, even after HHC removed that 24-hour requirement, many organizations, I think this is a very safe thing to do, have continued that, or at least to be able to.
I've seen people change over the past.
Recently,
over the past 3 years, but
but it's still there. I mean, a very conservative approach would be to request that. And, again, if you put it on paper and, that's the expectation you set, you're protecting yourself legally, you're setting an expectation. What they do, once they go at home, then becomes their responsibility, not yours. If you didn't tell them beforehand that you expect somebody to be with them for a period of time,
right.
You are taking the responsibility.
If your policy says 24 hours, then you have to follow your policy. So that's
at least to tell them, but you can't enforce it. I mean, you're not going to go to their home.
But when you can't have the doctor say you can go to work in the morning and it's 4 o'clock in the afternoon, because now whoever's involved in your center is not following your center policy.
Very good point.
You want to watch and make, every year we're supposed to review our policies, right? So look at that one and see what it says. If it says 24 hours, have a chat with your leadership and see if that's how you really want it to be.
And of course, that was a great segue. Thank you very much into the topic of policy manuals. Policy manuals are always a challenge. We find as surveyors that we go in and, we have to, before we get the policy manual, we have to wipe the dust off of it first and before we open it. Sometimes we have to unstick the pages because they've actually never read those pages. The policy manuals that I love are the ones that are all torn up with yellow stickies on them all over the place and, coffee stains on every other page. Then you know that they're actually using the policy manual.
There's things called PDFs now.
Well, there is that. But to your point, Jen, I don't care whether it's a PDF. I don't whether it's a website. Yeah, Lori and I are looking at Jenna. What's a PDF? Why, I want that paper. But definitely. First of all, to that point, Jenna, there is technology out there that is, really helping us to spread widely, the documents. I think those of us that have been in the industry for a long time remember sometimes we just couldn't find the policy manual, not because there weren't 17 copies of it somewhere. It's just that somebody had it sequestered in another area. But now there is a widespread implementation. Jenna, you've also been involved recently with some of the online policy manual. How is that going?
It's a lot of work it's a lot of legwork in the beginning.
Yeah.
And some of the programs out there look very, very nice once you get there, but it's a lot of effort on the center's part to get it to that point.
Yeah.
But I mean, there are some very nice programs out there nowadays that you can manage your policy manuals online. A lot of my centers are more using it just, using document storage. Either they have a website that their employees have access to that the policy manual is available on, or they have a network drive that the policy manual is available on in a PDF form. But there are a couple programs that specifically index all of the policies
To make it easier to change and know the timing of the
change. And some of them are nice too, because you can have attachments to it. So not only can you have that, can they have the policy, but they can also have easy links to the resources that were used to develop that policy, whether it's a CDC regulation or a CMS regulation or CDC guideline or a CMS regulation and so forth.
I'm going to look at Sue Cronkite and Amy Cronkite since I just put their two names next to each other. Obviously, it's the mother-daughter team here. They never want to be called policy experts. They have. For whatever reasons, they've had some challenges lately with clients getting them to, keep on top of the policy manuals. But I think the lesson coming out of it, I just wanted you to kind of talk about some of the challenges that you have. I mean, yeah, you have a consulting firm like ours, perhaps, or a regulatory, services firm like ours that provides, assistance in putting together a policy. But it doesn't matter whether it's that or, somebody in your organization puts together a policy manual. What do you need to do with that policy manual once you've drafted it?
Well, I mean, they certainly need to review it. As an organization, they need to know what's in it and be following those policies. It's not just an instruction manual that we send over that you don't need. We're not putting together a crib. It's running your entire operation. So I don't think a lot of people realize how important those policies are. Yes, you need to show them to the surveyors when they get there, but you also need to be following them and know what they say.
Yeah. And giving feedback, whoever's in the different departments that are addressed, should be looking them over and making sure they're still current, that they reflect what you're really doing. Obviously, the board has to approve all of those. And, my biggest problem is I think sometimes people don't even know where the policy manual is.
Yeah.
I mean, it can get, that bad. But yeah, it's got to be, like John always says, a living, breathing document where, it really is your instruction manual for your your center.
You really need the buy-in of your employees because they're the ones, especially when you get into the more clinical policies, they're the ones doing the day-to-day, and you want to make sure that is up to date with what your current practice is. Some of these policies, I know people just reapprove every year, and they were originally written in 2006.
If that early, yeah, it might have been from the Stone Age.
Is that still what you're doing? We can update it from a regulatory standpoint of, oh, this new rule came out, we're going to add this policy in. But it's the older policies that you really got to look at. That is this still the way we're doing things? Is this still accurate to our center? And you really need the people from those different departments to be reading them and, given the opportunity to give you feedback. And I think some of my centers that have done the best job in the past year of reviewing their policy manuals have been the ones that really just broke up the manual depending on who the policies affected and gave it to people from that department and said, okay, you are now responsible for this section. And, let us know what and also give them the standards from AAHC and say, hey, like, what do you have questions about? What do you want to know? And then my one center came back with a whole spreadsheet of questions that their employees came up with. And some of them, were like, oh, it might have been in just a different chapter that they didn't end up participating in. But, it was really nice to see at my one center how much the employees did take accountability and pride in the work that they were doing to update that policy.
Well, the other thing too is, as opposed to us older people that liked the paper copies, it's great if you have it online, but you better make sure that your staff have access. You can't just have one computer that's used in one department, and so staff will not have access because it's being used for patient care. So that's something that you have to take into account, as well as that time factor that we talked about that we don't have for education. They also have to have the time to be able to access policies if they.
And the other thing, questions. Donna, your old center used to send out weekly policies, and that's when you'd be calling me up when I was your.
Donna is so itching. She's just been shaking, ready to talk about this thing. It's one of her favorite topics. Donna, so Donna Macchio is one of our newer. She's been with us over a year now, but she came from one of our centers, and she was very annoying with the amount of time that she.
Not say that.
I did, but she was the one that would keep us on track with the policies. So Donna, talk about your philosophy about policies, both when you're administrator and what you've brought to us here at HS.
So I think that as an administrator, one of the things I realized very, very quickly is it doesn't matter if I know all of the rules if nobody else knows all of the rules. And the best way to have them know the rules is to have them read the policies and live them. And so we did assign policies of the week. Every week, depending on how long the policy was, policy would be on a clipboard in the lounge, and every staff member was expected to read it and sign off on it. And that became part of their weekly in-service. But to Jenna's point about coming back with questions and a spreadsheet, it really got the staff engaged in knowing what the policies were. Sometimes they would ask questions about, I don't understand this rule, why do we have to do it? And just explaining it to them was very helpful. And sometimes the policies were not 100% correct. And we would be, I would have to go back and say, okay, well, we must have missed the latest update. Or I would have new employees who would say, well, at our center, my old center, we did it this way. And it would kind of get the whole conversation going. And it made it easier to update the policies throughout the year instead of just once a year, because there are so many people looking at them. Now, the hard thing about that is there are some people who just prefer not to read the policies and come and ask the question, what are we supposed to do with blah, blah, blah? And instead of answering the questions, I started saying, did you look at the policy book? Did you go find the policy book? Go read it. If you don't understand, come back to me. And that takes a little bit of practice. It took practice on my part because I wanted to help them and answer their questions, but that really wasn't helping them at all. So it takes a little bit of work, but once you get everybody engaged, it's a much easier process for everybody in the organization.
The big takeaway here is making sure that you keep your policy manual up to date, that you make sure that it's widely spread, and then your staff, provides input, to keep it up to date, and ongoing education. To Donna's point, just like that weekly thing that you did was very helpful to your staff, all of your staff, in front of a survey. That was not ever an issue. I did want to point out one thing about electronic policies and procedures is, one of the disasters that you could have is when your technology goes down. And if your policy manual is only available online, that's going to be a bit of a problem. So you should always have, a paper printout of your disaster plan. So let's move on to technology. I guess it's a good segue into technology. A lot is going on in this area. Judy, I'm going to look at you in the beginning as our medical record expert. Judy, tell us a little bit about how you become a medical record expert, first of all, and then talk a little bit about, or a lot, depending upon your energy today. We are doing this on a Friday. It's the afternoon, so we're all running out of energy here. But talk a little bit about where we're heading with regard to EMRs and the challenges that we have specifically in the ambulatory surgery industry with EMRs, which is very different than other settings.
Yeah. As I did research, when I got the education of medical records, it wasn't specific to ambulatory surgery centers, naturally. So then once I brought it home, so to speak, there are aspects that are just not the same. Just the review of the records. Hospitals have, the ability, the luxury, let's say, of having a whole department, that looks through and makes sure that the records are completed and accurate and legible and all of that. Your average ambulatory surgery center doesn't have that, nor do they have the time to have somebody sit and do that. We're lucky if we can just get like a nursing chart audit done, which does a good job, finding things that we should work on. EMRs do make it a whole lot easier. I review records for both completely on paper centers and completely electronic centers, and each has their own set of stupid. you know what I mean? With the paper ones, it's the normal stuff that you would normally, that this got lost, this didn't get scanned, this got scanned into the wrong patient, and all of that is human error, and that's certainly eliminated, once we get to the EMRs. Not a lot of EMRs were built specifically for us. And I'm sure people have come across this. A lot of software that we want to use, there's these, these web pages to help us keep track of all our paperwork, all of our quality improvement. They're not made specifically for us. We're different. We're like what did you call it, Christina? Redheaded stepchild.
I can only say that because I'm a redhead.
Because she's a screaming redhead. So it takes work. It takes work to either sit with your EMR vendor and say, okay, this is what I need it to do. These are the things I need it to capture. Help me make those changes. And most of the time, I'm hoping that your vendor will do that. Mm-hmm. And if not, fine, thank you. We ask. Now we're going to figure it out for ourselves. And then you have to put into place, we're not getting signatures from these patients on their discharge instructions. We know, we talk to them. We know that they understand, but I have no way of proving that it was done. And again, it comes back to, if it isn't on paper, it didn't happen.
Right.
And what I found the most difficult when I started to talk to people about, once I finished their review, is the way your record should work is so that a person could walk in and follow that patient from the moment they entered the door to the moment they left the door, and see in chronological order who saw them, what they did, what they saw, what vitals they had, and be able to follow it without, dropping a stepping stone. And I think that's harder for us. I think we don't have the manpower, we don't have the time, so we really do have to rely on that technology. Technology is just not quite there yet.
Yeah. That is so true. And there's some good products out there. It's a really
there are. I didn't mean to make it sound that.
And there's some really bad products out there too. We're certainly not going to mention them. But to your point, we're not to the point where we have a perfect system right now. We probably never will be, but it is a limitation that really the people that develop these systems aren't necessarily people that are going to be using them on a regular basis.
Yeah. Exactly. That's exactly true. The people that built them don't know the difference with an ambulatory surgery center, don't know what we're up against, don't know what our regulations say. So they never thought of putting it in.
Where do you think we're heading with regard to adoption of EMRs in an ambulatory surgery center? You probably have a good pulse on that because you work with so many centers.
Well, of the ones we have very few that are still on paper. In fact, it's getting to be fewer and fewer that have a hybrid model, because we do have hybrid models where a lot of it is put in and then the rest is scanned in. Even that's getting less and less. I don't think we're going to have a choice. I don't think anybody's going to have a choice, eventually. In fact, I thought the whole let's get rid of paper thing would have made it faster than it even turned out to be.
Yeah.
And I'm hoping that they're just going to get better.
Yeah.
I mean, we feel like they've been around forever, but they really are in their infancy. Let's be, those of us that were working in the hospital in like the 80s, the whole electronic thing is new, and it is in its infancy. So I'm hoping that it'll grow into itself. Does that make sense? Certainly grow into us.
Yeah.
What about the smaller ASCs that don't have a lot of the financial ability to implement it? We have a couple of those, Yeah.
believe it or not. The few we have that are still on paper,
Right.
exactly paper only.
Right. I think that's where you won't see them go over.
They'll
because
literally
The EMR should-
retire
for
before.
for
Yeah.
electronic.
To be honest, the one I have in my head that's on paper are the ones most willing to listen to me and make changes because they can.
They can very
I'll
quickly.
change this form,
Yeah.
and then I'll show my staff, and then it's changed. Where the other is, okay, I'll call my vendor, and then maybe my vendor will call me back, and maybe my vendor will help me,
And the vendor will charge me.
and the
That's
vendor will
right.
charge me, and they won't come in and teach my staff. So almost they're at an advantage because they have that control,
Mhm.
and you do give up some of that.
Yeah. There are other technological changes that are occurring. I'm looking at Jenna, who has been at the forefront of this and working with some of the new technologies for, checklists, incident reporting, credentialing, peer review, chart audits, contract management, policy manual maintenance, things like that. There's some great technology out there. You've had some experience with it. I don't want you to necessarily talk about specific products right now. And then we're going to look at our support specialists who actually use these products and enter data on a regular basis. And I want to have their feedback. But Jenna, why don't you start that conversation? Then you can turn it over to your friends.
So
Says.
I would say at this point, I've gotten to play with, I guess, about 4 different of the programs out there. Some I like better than others. I think a lot of it is what you put into it, you get out of it.
Garbage in, garbage out.
Yeah. I think you kind of have to really do a good job of demoing the different products out there and finding out what one's going to work best on what your priorities are, like what you need it for the most, because there's different ones that have different strengths and weaknesses. So I've found it for myself, it works very nice because, it's easier. I can go in and get all the information from my clients to do my quality improvement each quarter. I don't have to harass them. But also I know some of my centers, there's, I've got to have this paper, these incident report was filled out by this person, then so-and-so needs to review it, then so-and-so needs to review it, and then I'll get it back. And sometime in that process, it gets lost.
Yeah.
So a center that has their incident reports on an online program, it's not lost. It's always there and you always have access to it. So I know I've suggested that to a couple of my clients that have lost things a couple too many times. Have considered.
Yeah. But to your point, you do need to demo these things. You do need to talk to people that are currently using those products. We would be talking about a product that was perfect if one existed. Each of them has their strengths and weaknesses. And I think you've said this, Jenna, if I could take I think there's 4 major products. I think you said there's 4 major. If you could take all 4 of those and combine them, or take the best out of each of them.
Pieces of every one of them.
You would have a good one. So, our support specialists, Laura and Mary. Now, you don't necessarily enter data into it, but you're the one that's looking at that raw data, and then you take that data out and you manipulate it. So, from an access standpoint, probably even more so than Jenna, because Jenna's looking at the upper level reports and she's making you do all the real number crunching. The grunt work, right? So, what do you think of where those systems are?
I like the systems because it does cut down on emails back and forth. It makes it easier for the ASC because they're doing it in real time.
Right.
They're putting it in and then I can retrieve it. It's fast, it's easy.
It's like one pad of paper as opposed to
10
10
sheets of paper.
or binders,
Yeah, 5 million binder. I know I have one center right now that I get weekly emails. I have such patient satisfaction from back in 2003. How long do I need to keep that for?
About 1 week ago.
Right.
Yeah.
So, you're getting rid of all that paperwork that you normally would have, the surveillance sheets and the incident reports and things. It's all online, a lot less paperwork.
Well, it's a paperless society.
Yeah.
And I find I like it, and I wish every center would use it because
Legibility
easy to
probably is the,
read.
yeah.
It's easy to understand.
Yeah.
There's no questions whether it's a yes or a no or a maybe. I like them.
Yeah.
I don't care which one they use. Just use
Well,
one.
that's a very interesting point, Laura, because you work with I mean, I know Jenna does too, but you're really getting in there because you have to, be able to access that information,
Right.
be able to look at it quickly. And of course, unfortunately for you, you don't have the level of training that perhaps these centers have had on it. So, the ability to
It is me just nosing around.
Right. And being able to do that
It's
without
being able
having
to do that without, I will go in and click buttons to see what it brings me to.
So that explains why I get the phone calls from the company saying our entire computer system is broken.
It was Mary. Showing Mary, she started clicking buttons. I don't know what, things got crazy there. Yeah, but and because I'm allowed to do that, I can go in and look and navigate and see. I have found a lot of stuff that I never knew really was there.
Yeah. And it makes it much easier. As Jenna said, you're not losing that data. You're not, it's not even losing it. It's just, taking the time to find where you put it, say 5 minutes here, 5 minutes there, it starts to add up to real time in a
Also,
day.
and I know a lot of my centers like the dashboards to keep them on track of, for credentialing and employee files, especially like, what do I need to focus on, or for the logs,
Say, you need this.
Yeah, or reminders that kind of say, oh, we need to do the quarterly or the monthly or the weekly, whatever.
Yeah.
Are we on track with things? And it's kind of an in your face, that you need to do 5 million things on a daily, weekly, monthly basis. But, it's kind of like an in your face reminder of, it's been a month since we did this last, we need to get that done again.
Yeah. Let's move on to finance. My finance people have been itching here because they just love talking. Tony, we're gonna have to turn that microphone toward you since Tony is one of the most soft-spoken people on the entire planet here. So we probably have to put that microphone right in his face.
I know some people who wouldn't say that.
No, that's right. And actually, we can hear him very well. So I'm going to ask, Tony, Alex, and Zach, and of course myself on the finance side, just to kind of talk about some of the things that are going on right now. Zach, I'm going to put you on the spot. Zach is our expert in cost reporting. So those of you that are from New York State know what I'm talking about. But the reason we're talking about it is because there is a national movement to do cost reporting nationally. And so just a little bit of history here, hospitals, nursing homes, home care organizations, and do dialysis centers have to file cost reports too, Tony? Or anyway, organizations that are paid under the Medicare program are often required to file cost reports, and they have to be audited, which means that your financial statements have to be audited. And we are really one of the only industries, especially one of the largest industries out there, that don't file annual cost reports to the Medicare program. Now, the state of New York is an exception. State of New York requires cost report preparation for Medicaid. I don't really want to dwell because this is a single state issue, but MedPAC, which is a part of the United States Congress that reports to the United States Congress on a twice annual basis, about their recommendations for the Medicare financial reporting program, has been recommending for a good 15 years that ambulatory surgery centers be forced to do the cost reporting system. So, Zach, you head up our cost report division here. New York is the only state that requires cost reporting right now. It is not required from a federal standpoint. But one of the challenges, I'm also looking at Tony here, who used to, work as the chief financial officer for the Catholic Health System, in Buffalo, and you were responsible for overseeing the cost reporting system. Cost reporting is not a cheap process. So if this were to be something that were mandated by Medicare, you as a CFO, I mean, even in the hospital, is an expensive process, right?
Yeah, well, it's a process. Just in an individual hospital, we had one individual dedicated to for a good, quarter of the year.
Yeah,
it was a pretty big deal. All the step downs and everything, and of course. It's a big reason we needed to have audits.
Right.
You want to have an audit anyway, I think, because
Yeah.
I'm a financial person, but you have to have an audit in order to confirm independently those numbers that are, and the audit itself takes a lot of time.
Right.
And here in New York State, a lot of centers probably wouldn't get audits if they didn't have the requirement of the cost report. So it takes quite a bit of time, I think.
And of course, that translates into a lot of money too.
Yeah.
It's and often the price of the audit is dependent more. It doesn't scale dramatically. There's almost a base price, and the size of the organization is not going to dramatically change the amount of money that they're going to charge for an audit.
That's right. Mm-hmm.
Zach, you, as I said, you head up our cost report department. You deal with the auditors all the time. You pull together the information for the cost report. And FYI, for those that are not aware, Zach spends approximately 3 to 4 months of his life every year working on cost reports exclusively. And of course, then he's working 24 hours a day during the time frame that we're waiting, for the actual filing. Just talk a little bit about the process, kind of quickly, and the challenges that you have dealing with the auditors too as you're going through this, because our centers, again, this is not a requirement from a Medicare standpoint now, but it has been something that has been proposed by MedPAC over and over again, and it's possible that in the future that could happen. And Zach, the reason I want this is I want people to make sure they make it clear to their congressman that this is not something that we should be doing too.
Sure. Yeah. I mean, one of the biggest challenges we always typically face is just getting everything in a timely manner, honestly. So, in addition to the information that's coming from the auditors, which can be significantly delayed from time to time, depending on if this year we're running into the issue with some of our clients' tax returns are on extension, which delays the audit, which delays obviously the results of the financial statements. So getting everything to us in a timely manner, not only the stuff from the audit, but everything else that comes separate from the audit. So the revenue by payer data and the salaries and wages data. What we always emphasize is as early as we can get it into us as possible to process is good. That way we can be ready to basically file everything as soon as the software is released. But beyond that, one of the things we run into typically is just not everything that we get looks exactly the same from client to client, which is typical. The type of reports that we'll receive for revenue are different from one to another, which just sort of poses a unique challenge. But yeah, as long as it is in a timely manner, that gets us the most time to work on that and hopefully get it as early as possible, and saves us a lot of stress down the line when we get to once the software is released and when we actually get a deadline.
Yeah. To his point, that the challenge with the cost reporting is that it is done using computer programs. The programs are developed by in New York, it's the New York State Department of Health, and for those that are having to report those other entities, not ASCs, it's developed by the Medicare program and published by the Medicare program. A month or so before. Or a couple months before the actual cost report is due. So it's an expensive process. We will certainly inform you on the podcast if this is something that eventually gets added to one of the requirements, because that would be a huge issue for our organizations. Tony, I want to talk about financial reporting for a bit. We as a company, Ambulatory Healthcare Strategies, don't do a lot of financial reporting right now. And Zach is involved in that process also. But I just want to talk a bit about, where so many of our ambulatory surgery centers are small. They don't have the resources to be able to put together regular financial reports. And yet our doctors are demanding more and more information. It's not like the good old days when we were making so much money that it really, regular monthly financial reports were necessary. You've been, you used to run ambulatory surgery centers, of course. You used to much bigger organizations too, but you kind of have an interesting perspective going from a, big hospital to when you retired. I don't understand your definition of retirement, because it's, I think, differently than mine.
I'm on my third.
Yeah, retirement.
Post-retirement.
So I know you thought, I don't know. Did you think it was going to be easier going to an ambulatory surgery center from the hospital?
It was different.
Yeah.
I didn't know what I thought, but it was definitely different. As I was sitting and thinking about it, at the hospital, it's a larger organization, as you said, and we had robust financial management departments.
People with college education specifically.
College educations, and even in we'd have 4 or 5 accountants,
right?
Not to mention all the support people, paying bills. We'd have an army of people paying bills and an army of people sending bills.
Right.
In an ambulatory surgery center, we just don't have that robust of team.
Yeah.
And nor do we usually have that level of education and competence.
Right.
And often we don't have the financial language or the financial understanding of the value of a good financial reporting to the owners and the public as required, because not only are we talking about the owners, but if you need financing, you need to have a good record of what your financial position has been and currently is when you go to a bank.
Yeah.
So it's not unusual for an ambulatory surgery center to not have that, again, robust of a system. And when the finances are not as I think, as you said, maybe there's some downturns, or we're not making quite as much money. Want more response, more answers. But
why am I not making the money I used to make?
Right, but you don't have the systems or the reportings to really talk about that.
Yeah.
And then that becomes, I think, an area that becomes a mystery to many administrators in ambulatory surgery, because that's really not their background.
Yeah.
So I think that, it's an area that probably is becoming more and more of an emphasis that we need to have a good financial reporting, especially as it's not as easy to make money as it maybe was, in earlier years. And then, reach out and get help for those things. Just changing, just converting from, something simple as converting from a cash basis to accrual basis, so that other accountants and banks and that can understand what you're talking about, and also be able to compare it to other facilities, and then also with those numbers be able to do benchmarking, financial benchmarking that's going to make sense,
right?
To other compared to other organizations that are keeping track of where they're at financially. And then, of course, to the owners, to the partners, giving a good reporting, and then being able to say, here's where our shortfalls are. Here's where we need to make some improvements. So it's an interesting area. It's kind of a mysterious area to maybe, I ran ambulatory surgery centers from the business side. So I really needed to get help.
Yeah.
On the regulatory side, I got your company to come and help me.
Yeah.
And I had good nurses to help me because I needed that support. Well, we have nurses that are good administrators. Yeah. Probably much better administrators than I was, but they need to have support on this business side. And so that's another area that we can, I think we can help with. Yeah. And not just be advertising here, because there aren't that many of us, but I think it's something that needs to be something you're thinking about, especially on behalf of your owners.
Yeah, to Tony's point, we do offer those services now. It's not a big part of our business, and if we get too many clients, we're going to have to expand. But I think the need for people that understand finance, are real finance experts, and more specifically, people that understand ASC finance, are extremely important. And to that end, Tony, you were leading into the next point, which is really that financial projections are an important thing, even for the smallest organizations. When things are not going well, you want to be able to have a way to determine what is the future going to look like. If this trend continues, what are your financials going to look like?
Yeah, that's a good point. I think when physicians come to us and they want to do a new center, the first thing they know, they need financial projections. Yeah, and that's right, they do. And so that's what we do to help them begin start new centers. But that's something that's also needed along the way. Yeah, sure. To redo a business plan. Well, business plans that I redo, the first place they start is with the financial projection.
Yeah.
Of course, you need with that includes all kinds of assumptions, all the things you need to consider financially and operationally to come up with where you need to be, where you want to be, how you're going to get there, and maybe setting your goals realistically that you might not be able to get that particular goal. But so it's financial planning is really important. I think now more than ever.
Right. Well said. And FYI, I have been asked to speak at ASCA 2024 on the topic of developing financial projections in ambulatory surgery centers. So the Education Committee, which Lori and I serve on, has recognized that that's one of those things that our audiences are looking for. Tony, I wanted to finish by just talking about something that's going on in the finance world that not many people necessarily would know. But, it's well known that we've had a problem with inflation. Food costs have probably been the highest problem, or the highest amount of inflation, energy costs, which permeate all aspects of our economy, because you got to transport everything to its end destination, and I think that I was hearing that energy costs are up somewhere around 40% over the last 3 years. Which has had a dramatic impact on stream into all those things. And that's a big component of the cost increase in food also. But we know we have to bring it under control. The inflation rate is way too high. It is hurting the economy. It's hurting the pocketbooks of individuals. And unfortunately, that means that the government has to step in and raise interest rates. We'll go into the economics of it. There's plenty of books out there that will explain that. But the most common way of reducing inflation is by raising interest rates and cooling the economy down, which unfortunately means there's two things, that it starts putting you into a recession. We know that we have some signs of a recession, but even if a recession doesn't hit, our challenge in the ASCs is going to be the impact on the capital markets. We are capital intensive organizations. We need capital in the form of loans to be able to buy equipment, to be able to build centers, and sometimes just to be able to operate, in terms of being able to get over those tough parts when we need some additional cash flow, like short-term financing. So I really don't have a lot to say in this other than to say, be careful in the future. I mean, as we're sitting here in September of 2023, I think you agree with me, right, Tony, that now's the time to finance, because very shortly you might not have that capital access.
Yeah, well, we are of course already seeing interest costs increasing from substantially from where they were, of course, 2 or 3 years ago, but even from earlier this year on new projects where we're doing projections and looking at where we're going to be, once we start building, and those interest rates keep creeping up. So if you need financing, it's better to get it now. But get it while the door is open. Don't wait until you have a dire need for it. Get it while your finances look good. And whether it's a long-term financing or capital financing, working capital financing, that is. And, working capital financing, that's the cash for your day-to-day work. If you need if you think you're going to need a line of credit next year, don't wait till next year to get it. Get that $500,000 line of credit this year. While the interest rates are still low, although that could fluctuate with the interest rates, but your finances are going to be in better shape. The government as the Fed, whatever, I don't think they're going to be happy till they get us into a recession at that point. So,
because all the actions that they've taken so far have not cooled inflation enough. I mean,
and that's their concern.
The consumer price index is going down, but unfortunately, the consumer price index doesn't calculate some of those things, especially in surgery. Some of our costs are going up much higher than CPI, but it's not being reflected in that. And then the other problem, of course, is is food and energy.
And I mean, just the little bit of analysis that we do on behalf of surgery centers, just looking at the cost of supplies. Other things are going up, because of the increase, but the cost of supplies is really going up. Implants especially, and we're talking about medical supply providers who have always made sure that they're getting paid plenty of money. So if there's any hint of an increase in costs, they're going to take advantage of it
before it really actually hits the supply chain.
There, but and so just seeing those little bit of increases, you can really appreciate the Fed trying to keep control on inflation, because if we have inflation that is, the least bit runaway, it could really be damaging to our whole economy.
Right.
So
Absolutely.
It's really necessary, but you need to watch out for your store.
Yeah.
your business. Yeah,
And by the way, some of my conversations with vendors out there have indicated we've heard about supply chain challenges with pharmacy. I think that's the one area that I'm very concerned about, that drugs might become in short supply in certain areas. So keep an eye, have very good vendor relationships and keep on top of that, because the rumors that I'm hearing, I won't even really call them rumors, that the straight out, as a matter of fact, we're going to have a couple of pharmacists on over the next couple of months talking about some of the issues out there. So stay tuned for that.
Some of the problems there, it's not just that the supply chain, but the supply. Some large pharmaceuticals are getting out of producing certain drugs, and that's
or moving offshore because they just can't afford to do it here in the United States. Yeah. We're going to finish off Mike D'Ambrosio and Alex Borneman are here also. You haven't really said much yet. They thought they were off the hook as we're getting toward the end, but
I think I fell asleep.
Yeah. No, I'm so sorry, guys.
The finance part, right?
That's right. So you're not off the hook. And why did we save life safety to the end? Because I don't know why did we, because it always depresses people, Alex.
It's everybody's so leave them depressed.
Yeah, that's a goal. Bad theory, very bad theory here. So why don't we it goes without saying that surveys are getting tougher when it comes to life safety. Alex, why don't you start by talking about some of the things that have happened recently?
Yeah, and I think the biggest reason why there's surveys that are getting tougher is that we've had the same book for quite a number of years. When CMS first adopted the 2012 life safety code, that was back in 2016 and really 2017 when it really started getting enforced. And surveyors didn't know anything about it. Now we've had it for so many years. Surveyors are getting very savvy.
Even Lori is starting to understand some of the life safety.
Yeah.
No, Lori's sleeping. She's going to learn.
I think Lori understands life safety as well as I understand infection control.
No, I think I understand life safety a little bit better.
Ouch.
Shots fired.
Friday at 3:30. That's why it is.
Yikes. That youngster.
Yeah. But so surveyors are definitely getting trained better in life safety, and they're having experience in the field. We've seen a lot of issues over the recent years with electrical citations, that a lot of our centers are having difficulty getting their electricians and their electrical engineers to actually correct issues appropriately, even after they're cited, and really doing a detailed review of those electrical systems.
Well, and I think it's fair to say even finding people to do this work now, let alone finding competent people to do this work, or people that are experienced in the industry, is a challenge. Ongoing supply chain.
There's just not the experience in rectifying those problems.
Right. In finding any sort of contractor. I know we've had clients that have gone through 3 different medical gas contractors that, without success of actually correcting their changes post-survey. So, and then that doesn't even count, all of the little things that have to be done around your center for, just regular maintenance, and finding those staff members that have the training necessary for this industry.
What Alex is actually alluding to is that we talk a lot about finding nursing staff. We talk a lot about finding, surgical techs. But even receptionists and even, maintenance, it's not even, you don't necessarily need a maintenance person to do a lot of this life safety stuff, but you have to have somebody that's at least comfortable dealing with it. Well, that's not easy.
Right. And you need a contractor. If you don't have somebody in-house that can patch a wall, you need somebody outside.
Or that can fill a hole.
Right.
Yeah.
We're running. I think it's that shortage of labor, throughout the industry that's permeating through the entire organization. And with drills, we're seeing drills not being completed. They need to be quarterly.
Yeah,
and you're just not seeing some of those done on a quarterly basis. Again, because priorities, are such, and there's just such a time constraint. So. See quite a bit of that too.
And there's a lot of citations going out there, right now for failure to do those drills,
right,
or failure to do them correctly. Failing to, keep in mind a drill's got to be, scenario based. You have to have a scenario. You have to walk through it. You have to do an analysis of what's going on. They have to be unannounced. You can't tell them what's going to happen. And it's got to be at different times during the day, which includes during surgery. After an organization has been cited for a problem that requires more than 45 days to fix, we run into what we call time-limited waivers. You've had the pleasure, I'm being sarcastic here, of filing quite a number of waivers. I don't know if you've ever added them up lately, but you've had, and keep in mind, time-limited waivers or these type of problems with our clients tend to happen with these older facilities that have, they might have passed the survey in the past, but the surveyors haven't been that experienced in, finding these problems. They didn't recognize or didn't see it in the last time, or those organizations are being held to a higher standard because people are actually reading the standards properly. So that puts us in a position where even an organization that's been doing very well on life safety surveys in the past suddenly runs into a problem. And what do we end up doing?
Yeah, we have quite a number. I know one client alone, I think, required 9. So
yeah,
that certainly boosted the number, and they're becoming, again, more prevalent as surveyors become, life safety surveyors become more attuned to the requirements. Time-limited waivers, it varies. The requirements vary across accreditation organizations and states. Most states have their own time-limited waiver form that they want you to use. And then the accrediting bodies, I know AAHC has a number of items that they want, but no format. So you kind of get to create your own form and fill it out. But generally speaking, what they want to see is, okay, first off, what were you cited for? That has to be in there. And then what are you going to do to correct it? What is the time frame and the major milestones of the corrections? And then also, what are you going to do to mitigate the risks in the meantime, both from a life safety standpoint, but a patient safety standpoint? And then from there, some like to know the costs as well, especially the costs related to any mitigation that you might be doing. And there's also, when there's patient safety concerns, they like to get a signed letter from the medical director, and at times signed letters from other contractors involved, electrical engineers and the like. So there's a lot of different elements that can come into play with time limited waivers. And unfortunately, the fact of the matter is, you put all this work in, you submit it. Sometimes you even get feedback from either the accrediting organization or the state. But then once it goes to CMS, you usually never hear back until you've completed the work, and you tell them before it's actually even been approved that, hey, we don't need the time limited waiver anymore because, we fixed the electrical system now.
2 years ago.
Yeah, 2 years.
Yeah.
And it is an important point too. They have been trying to limit the amount of time that they are giving centers. And what that means is it used to be basically 3 years was the maximum that they'd be giving out. And that's still the case, that's the maximum, but it's really more, they're trying to get it down to about a year for most items, unless it's a major improvement. And I will tell you, because of staffing issues and because of, sometimes it's just people dragging their feet, but it can be hard to meet a year on some of these issues.
And I think supply chain issues also come into play, where materials, are in short supply in a number of different areas. So that can also delay the project.
Yep, absolutely. Yeah, the going rate, I think for a generator was about 18 months, about half a year ago. I think it's improved since then, but it is important to keep in mind that doors, and any major pieces of equipment could have significant delays in your project.
Yeah, I mean, if you're looking to build a surgery center in the next year, order your generator now. I'm not kidding. I mean, we had a center that was delayed we've had centers that have been delayed many times for generator issues. It seems to be one of the major issues that, either procuring the generator or the regulatory issues with setting it up because of the fuel. There's always regulations surrounding how you manage the fuel there. So
Sterilizers have been another.
Thank you. Yeah,
sterilizers are a big item as well. I know I'm on one project right now where sure, maybe we can get the rest of the project done by the end of the year, but will a sterilizer be in time?
Yeah. Alex, there have been some very difficult situations. We were brought into a situation where a center had significant citations, and then realistically, they could not meet them. So became an urgent issue, and they were basically asked to shut down operations. Talk a little bit about that. Again, it was a client that we were brought into after they had been cited. It was quite apparent that they had problems, and had they hired a company like ours first, I think they would have been able to fix them before they became major. But describe a little bit about the challenges that you have with that.
Yeah, there's quite a number of changes throughout. Staffing issues, unfortunately, tend to be kind of forefront in the industry right now, and major problems can occur when you don't have leadership in place to ensure that you're following all of the regulations. And that's kind of the day in, day out solution to a lot of the problems is, in this particular case, but also in general, how you avoid being this type of center is having that solid leadership in place. But in addition, other issues that come into play, having good documentation of your building and how it was constructed, approvals along the way, changes that might have been made. Because in this case, you go back and when DOH is asking you, hey, why aren't you meeting the requirements of many basic things like something as minor or seemingly small as the size of a bathroom, for example. Why is the bathroom not ADA compliant? That could be solved by having proper architectural drawings to figure out and documentation of submissions to DOH to determine, okay, why were those changes made or were they approved? If you identify changes that were not approved, digging into those and making sure that those can be remedied before you have a citation along those lines. Also, getting advice from consultants. I mean, unfortunately, not to toot our own horn, but you need consultants to help you verify that your facility is in compliance and identify those areas of risk. If it's not necessarily saying you're going to be able to fix all of those areas of risk, especially when it comes to the building immediately, but at least you've identified them, go down the process of what would the cost be. And then that really helps you with your risk management plan.
And it'll help you to know what are the low-hanging fruit that you can definitely fix that it's not going to cost you a lot of money. They can still get you into a lot of trouble. And what are the ones that are so expensive that you're likely to have to do a time-limited waiver or, start doing some work on it even before the surveyor cites you for it.
Right. A good example of that would be you're missing a pull station, a fire alarm pull station. That's a pretty cheap fix, but it can be a condition level citation depending on where it's missing.
Yeah, and keep in mind that life safety issues could also result in immediate jeopardy situations. And immediate jeopardy situation is where you cannot continue operations until you fix that problem, or at least have a very succinct plan to fix that problem.
Yeah, and some of the areas that we've seen this come into play are medical gases. And it's interesting because it is almost more of an operational item. You order too much gas and you store it outside of your medical gas room, and all of a sudden you've got a possible immediate jeopardy. Or you have oxygen tanks on all of your patient beds, and there is a limit that you can have outside of the medical gas room, and it's important to keep that in mind and be aware of that. Track how many tanks and what volume is outside that room to make sure that that's not an issue. But yeah, it is interesting how a good number, we always think of immediate jeopardies on the clinical side, but the life safety side, you can have them too.
Yeah. I want to thank all of my team here. You have been, first of all, you've had to listen to, an hour of other people speaking, and I appreciate your patience. That I just want to say I have such a wonderful team here. I'm so proud to work with all of you. We come together, as I said, twice a year to do these retreats. It's very important for our clients. It's very important for us as a team, especially since we're all remote. And I appreciate all of the hard work that you've put into these last 3 days. And we made major decisions. We made major, industry leading, conversations about what's the best thing to do. And we're proud to be one of those organizations that really is leading the industry and in improving the safety of our patients and our organization. So thank you all.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff and other events in the ASC industry.
So as we talked about earlier, the New York State Association of Ambulatory Surgery Centers 2023 annual conference will be held October 4th through the 6th, 2023 at the Desmond Hotel in Albany. And I'm going to be speaking and moderating some of the sessions, and we'll have a special episode with interviews.
And the Washington Ambulatory Surgery Center Association's annual education conference and trade show is November 9th and 10th, 2023 at the Tulalip Resort and Spa in Tulalip, Washington. John will be speaking there, and we hope to have a special episode with interviews.
And then if you go to our ASC Central website, that's at asc-central.com website, we've announced 2 conferences. The first one is on November 16th. The first one is November 16th, 2023, and it's an introduction to finance and accounting for ambulatory surgery centers. And it's going to be recorded live virtually, so you'll be able to attend virtually, and it'll also be available on demand after that date. And then on the next day, on November 17th, 2023, we're going to update our ASC Conditions for Coverage and Interpretive Guidelines Conference, which will also be live, done virtually, and will be available on demand after that date.
And ASCA 2024 will be at the Gaylord Palms Resort and Convention Center in Orlando, Florida on April 17th through the 20th, 2024.
And I've just been asked to do a second presentation. So the first one is going to be on financial projections, and the second one is going to be on one of my favorite topics, which is governance in the Ambulatory Surgery Center.
And then our upcoming boot camps, October cohort of the ASC Director of Nursing Boot Camp is October 31st to November 3rd. The January 2024 cohort of the ASC Administrators Boot Camp is January 23rd to the 26th. And they're all available on asccentral.com, our new website.
And that is asc-central.com,
yes,
but it's known as ASC Central, correct. And, of course, on-demand versions of the ASC Director of Nursing and ASC Administrators Boot Camps are available on our sister website, asc-central.com. And don't forget about all of our recorded events, also available on asc-central.com, and that's our 2020 credentialing conference. We're going to repeat that sometime in January 2024. And our fall 2022 finance and accounting conference, our conditions for coverage conference recorded in 2021, which, as we said, we're about to re-record that in November, and our medical director conference, which was recorded in 2021. And you might also be interested in our June 2023 on-demand version of the multi-state conference, which is eligible for a massive 16 AEUs and 4 IPCH credits. So if you're short on your credits this year, this is a relatively inexpensive way to get those credits, as well as have some great topics. We talked about infection control, life safety, survey preparation, human resources, introduction. There was an introduction to the Medicare ASC payment system. There was a pharmacy discussion and a discussion of staff retention. It was really a great conference, and it was so successful that we're already planning the 2024 multi-state conference. And we do want to remind everyone to become a patron member of the podcast. The patron member program, which is also known as ASC Central, is available on ASC Central as an exclusive membership website that provides a one-stop ASC regulatory and accreditation, compliance, operations, and financial management resource for busy administrators, nurse managers, and business office managers. And resources include some of our virtual conferences, links, policies and procedures, forms, and fire and disaster drills. And membership helps to defray the costs of producing this podcast, including research staff, travel costs to conferences, equipment costs, and production costs. And for more information here, you may visit asc-central.com. Thank you for joining us for this episode of the ASC Podcast with John Goehle. If you found our episode informative, we really encourage you to share it with your friends and colleagues in the ASC industry. And don't forget to hit that subscribe button so you never miss an episode. And we'd love to have any feedback about our episode and ideas for future episodes by sending us an email at comments@ascpodcast.com. We'd like to give a special thank you to our great team here who make this podcast possible. Our sound editor is Susan Cronkite, our executive producer, John Goehle, and our dedicated research team, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Calritis, Jim Masters, Amy Drabano, Lori Rodricks, Kathy Foti, Donna Macchio, and Christina Norman. We really couldn't do it without them. Our music is provided by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast platforms. Thanks for listening.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, Trivalence, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable insights. Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute, legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you are interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.